Our objectives today are reviewing the upcoming virus season surveillance and discussing the national respiratory case definitions and reviewing the surveillance education that we've done for the last 2 sessions with a few case studies. Okay, respiratory surveillance using the 2017 national case definitions. There are national long-term care surveillance definitions that were developed by members across Canada, and there were some people from Manitoba involved in this working group that developed these national surveillance definitions, and the most recent ones were published in 2017. They are currently under development again, but right now the most recently published ones are 2017. And these were from experts in long-term care and infection prevention and control, including infection prevention and control professionals, and as well as infectious disease doctors. These definitions are for surveillance and are encouraged to be used across the country to standardize how long-term care surveillance is conducted. We will go over the respiratory definitions as these are the ones that are supposed to be now used for this upcoming season. And I will show you the small differences that exist between what you have been using and what you will be using. And I've adjusted the data collection sheets that you guys currently have that you normally use that I provided to Carol for these new definitions, so that it should make it easy for you to just change the way you do business, but it should still flow well. So, getting started, the common cold definition. Everything is exactly the same in terms of the common cold definition. For the national definition, it's common cold or pharyngitis. At least 2 must be present: runny nose or sneezing, stuffy nose such as congestion, sore throat or hoarseness or difficulty swallowing, dry cough, swollen or tender glands in the neck. And now you also can have an NP swab positive for a respiratory pathogen as one of your 2 criteria. That never used to be a choice. For influenza-like illness, this definition has actually changed quite a bit in terms of how it looks and what you get to choose from. Criteria 1 and or 2 must be present, as well as 3 or 4. Okay, I better confirm whether that's 3 or 4 or 3 and 4 before I send that out to you. Fever, that's important. So fever has to be present and or number 2, a new or increasing cough. 3 must be present and or, not sure which one, 4, I'll confirm, but I think it's 3 or 4. At least 2 of the following influenza-like illness subcriteria. And there's 2 new ones: chills and new headache or eye pain, as well as the ones that you know from before: myalgias or body aches, malaise or loss of appetite, sore throat, joint pain, or an NP swab is number 4 for influenza virus. That'll confirm that it's influenza, but it is under the influenza-like illness category. Pneumonia has not changed much at all except how they describe it. Criteria 1 or 2 must be present, or criteria 1 and 3 must be present. And I'll go through those. Number 1 is the interpretation of a chest radiograph as demonstrating pneumonia or the presence of a new infiltrate. At least one of the following respiratory subcriteria is number 2, and those criteria are new or increased cough, new or increased sputum production, an oxygenation saturation rate of less than 94% on room air, or a reduction in O2 sats of greater than 3% from baseline. New or changed lung examination abnormalities, pleuritis, chest pain, or lastly, a resp rate of greater than or equal to 25 breaths per minute. And number 3 is at least one of the constitutional criteria. And those have changed slightly as well in the national case definitions from what you're used to using. So I'll go over those at the end of my list here of respiratory definitions. The last respiratory definition is exactly the same as what you're used to using, and that is the lower respiratory tract infection. It has not changed at all. Now this is really small, so I'm hoping that when you get this presentation you can look at this more carefully, or when you get the form, the data collection form that Carol will probably send out to you, then you can read it in more detail. But I will go over the constitutional criteria for the new national case definition. And I will show the differences between the old and the new. It includes fever, the same as before, and fever is a single oral temperature greater than 37.8 or a repeated oral temperature greater than 37.2 or rectal temperature greater than 37.5, or and this is something new, a single temperature greater than 1.1 degrees increase over baseline from any site, oral, tympanic, or axillary. The leukocytosis definition has changed in that instead of calling it white blood cells greater than 11 to 10 to the 9th, it's not 11 to 10 to the 9th anymore, it's 10 to 10 to the 9th leukocytes. And it doesn't actually include a left shift as an option. So that's a change. The acute change in mental status from baseline is all the same, except it takes away some of the examples. So the examples you've had before, such as they now use just acute onsets. They don't give you an example, fluctuating course, inattention, or either disorganized thinking or altered level of consciousness. But there's one new whole section that's part of the constitutional criteria now. It's called acute functional decline, not the acute change in mental status from baseline that number 3 was at. It was supposed to be number 3. My numbering is a little off. Sorry about that. The acute functional decline, a total new 3-point increase in total activities of daily living with a score that ranges from 0 to 28 based on the following 7 ADL items. And each gets a score from 0, which is independent, to 4, which is total dependence. And this is somewhat subjective. But you have to have a 3-point increase for you to be considering this person as having a change in constitutional criteria. And here are the criteria: bed mobility, transfer, locomotion within the long-term care facility, dressing, toilet use, personal hygiene, and eating. So if any of these activities of daily living has changed and the amount, the change between them all increases by 3 points, then they've had a change in their constitutional criteria. So that's something quite new, and it will require some feedback from the frontline staff for you to be able to do this sort of assessment. And I hope that the charting will be able to support this. Otherwise, you will have to work with the frontline staff to determine how the patient is doing. Moving on to case studies calculating rates. So we will go over some questions related to the respiratory and definitions at the end of the presentation. So this is based on the surveillance presentations that I've done over the last 2 sessions. So Site A, I'm not going to give it a name, has 3 cases of MRSA in 1 quarter. And it has 8,665 patient days for that same quarter. What is the rate of MRSA per 10,000 patient days, and how did you calculate that? So if you had your calculator out, this would be how you would calculate the MRSA rate. You would take the 3 cases, you would divide them by the patient days that the facility had, which was 8,665, and then times it by 10,000. And then you'd get a rate of 3.46 MRSA cases per 10,000 patient days. So if you wanted to work on this later on your own, just check to make sure your answer matches this, and then you'll know that you got it down pat. Facility B, so this is a new facility, has 2 cases of MRSA in 1 quarter and 3 cases of CDI, C. difficile. And they have 11,642 patient days for the same quarter. So they've got more patient days than the last facility. It's probably a bigger facility. What is the rate of MRSA per 10,000 patient days? And what is the rate of the CDI per 10,000 patient days? And how do you calculate them? You don't calculate them together. You calculate them separately. So the first one would be your 2 cases of MRSA divided by the patient days of 11,642 times 10,000. So you get 1.72 cases of MRSA per 10,000 patient days. To calculate the CDI rate, you've got 3 cases of CDI divided again by the patient days, 11,642 times 10,000, and then you'd have a rate of 2.8 cases of CDI per 10,000 patient days. For those ICPs that are relatively new who might need a little extra practice doing this, feel free to use these examples, and you can contact me for more. I've got other examples that I can share with you, and we can work through them together if that would make you more confident. And then to compare site to site, which is now possible because you've now changed them into rates, I've put this into a graph, and the first column here is the rate of MRSA. It's the light green. So facility A has a rate of 3.46. So the graph almost goes up to the 3.5. For the light green, that's its MRSA rate for that quarter. And facility B has a rate of 1.7 for MRSA, so it goes halfway between the 1.5 and the 2, and that's the light green column. But the CDI rate was higher. It was at 2.58, at facility B. So blue bar is facility B's CDI rate. And you can notice immediately, because graphs are great that way, that facility A had no CDI, but facility B did. And so that's why comparing by rates works really well, because now you can compare a big facility, or this was facility B was bigger, to a smaller facility, which was facility A, because you've converted the case counts into rates. Now I've sort of breezed through everything rather quickly, but I have everything on this presentation in writing, so if you have more questions you can ask me later.